For the introduction, Harvey standard selection for the transcatheter ASD closure is the diameter is around 5 until 14 millimeters with adequate rim with PVR less than 5 wood units and the RR ratio less than 0.33. However, with the advance in technology of device and technique, the difficult ASD unstable device closure before could be closed right now. So this is the emerging of the transcatheter closure in my centers. It's increasing in the last 2 years. This is, as you know, the standard technique of the implanting the ASD from the right upper umbilical vein technique or from the left, the classical one. So, what's the difficult ASD or unsuitable device closure before versus a large second ASD? The second one is a deficient rim, floppy and malalignment rim. The second ASD with pulmonary hypertension with R ratio more than 0.3 and ASD in infant less than 10 kg. So, what's the large ASD definition is from the TE diameter more than 20 millimeters. The very large ASD is more than 30 millimeters in adults or more than 50 millimeters per meter square in children. It's often associated with deficient rims and pulmonary hypertension. Technical issues is the device approach sometimes has an incorrect angle, and the risk of the protrusion in the left atrial is right atrium. So this is the study. You can see from full study, there's a high success rate in transcatheter closure in the large ASD. However, in extreme large ASD, the success rate is low, only 17% may be considered for transcatheter closure. And we will ask the surgeon the data in the large ASD in National Cardiovascular Center is quite challenging. It's around 90 patients with the success rate here, 100% in 2017. First, we to use the alternative technique. First, we use the balloon-assisted technique. This the TE diameter is 26 until 36 millimeters. So it's an oval shape of the ASD. So we put the balloon, this balloon sizing to assist the position of the device, and we can easily protrude the left atrial disc first, and then the right atrial disc. The second case is also big ASD. You can see there's 29 to 32 millimeters. And then we put in the left atrial roof technique, so we prevent to let left atrial disc protrude to the right atrium. And then this, you can see the later, right? Now it's very nice. And how about in children? We have an experience for the body weights is the children body weights 10 kgs with the diameter of ASD is 18 millimeters. So there's a 36 millimeter per meter square. You can see from the left side we use the soft device, and then we put from the right upper pulmonary vein technique. And the devices sit nicely there. From the T evaluation is good condition. Okay. This is a mild alignment rate. Previously, it's very difficult to put the device in mild alignment rate. So we make another technique by using another catheter to realign the device. And then, how about the double layer T rate? This patient, 51-year-old patient with the secondary SDS. We do the conference in my center, and then they say it's not suitable for the device closure since there's a double layer of the SDC ring. And I try with the right upper pulmonary vein. Then you see on the right side, we deploy the device in the pulmonary vein, and then put the right atrial disc, and then I push and pull gently, and then the device sits in that position. Next, this is our new cases, the secondary ASD with pulmonary hypertension. So we have an experience in Indonesia, 5 cases, 3 cases in a national cardiac center and 2 cases in another hospital. It's done with my friends. You see this R ratio is quite challenging. Before on the baseline, the R ratio is 0.5, 0.45. After we do the phosphodilator test with 100% oxygen, the R ratio is going down. As you can see, the pressure. The red one is the aortic side, and the blue one is the pulmonary one. So that's before the procedures. So we use the fenestrated device, it's a manufactured device. So this is the TV, and then you put the device from the right vein. And then the results are immediate form pressure from the pulmonary artery. For the functional state of the patient is very good. Patient in good condition. Now, for after 3 months, the patient functional class decreased from the functional class 3 to functional class 1. Very good. And then this is the second case, the 41-year-old female with large secondary ASD and severe pulmonary hypertension. But see the graph, the systolic pressure exceeds the pulmonary systolic pressure exceeds the systemic. And then we count the R ratio is 0.8, quite high. And after phosphodilator test, it's still high, 0.43. And then what should we do is we put again the fenestrated device, and after the observation, you can see this is a direct pressure on the left side, and then after 10 minutes, there's increase in the pulmonary pressure, and also the aortic pressure is increasing. So it's acceptable. So decide to detach the device. So this is the T procedure. You can see the shunt. It's left to right. So it means the right heart chamber pressure is falling down. So this is also the challenge case in infants, less than 10 kgs. We did several cases. This is the first one. The baby actually with the second ASD with the CVPS. So in the first week of life, we did the pulmonary balloon pulmonary valvuloplasty. And then after that, the bluish diminished, but it started from the 4 months. This is the Gibson and then failure to thrive. So we decided to put close the ASD by device. So we put the ASD with there's a very good position, and patient in a good condition also he can grow well. So the conclusion with the advance of the technology of direct device and techniques, recently the challenge and tough ASD device, ASD cases can be closed by device. So the transcatheter approach is a method of choice for closure almost all the secondary ASD cases. Thank you very much.
Thank you.